Hello.
Good morning, Dave. Herms, can you hear us okay?
We can hear you. We can hear you perfect. David, we got a couple of great cases, we think, very instructional cases. Today's going to be physiology and image rich. We were listening to Mort, and we were just remarking that you're not the only one that's learned everything that they know about physiology from Mort. He's spectacular, isn't he, Herms?
Yeah, we both tapped him on the shoulder a lot.
Yeah, exactly. Aloka's working in the other room. He is putting an Impella through a crazy tight valve, and they got a great case. We're going to start, introduce the room to you, but first, Dave, who's on the panel?
There's medicine for that.
I got Nishant Gupta, Mort Kern, Michael Kuchar, and Jonathan Schwartz.
That's great.
Aside from myself. Sorry.
I know Nishant's a fan of what we're going to do, and I talked about this last week. Okay, in our room we have Mackenzie standing right next to us, very experienced scrub. We have Jeremy. Jeremy and I have spent a lot of weekends and late nights in the ICU and in the cath lab together. We have Steve, he's circulating. Of course, you know Jim Hermiller. We have Steve Nelson, our clinical support from Shockwave. I got Vinky Ramaya. He's going to be contributing on this case. We got Bimal Padalia, and we have a young student, Parker Fitzgerald, is in the room also. First thing I want to introduce before we go to the case is this system here. Can you move your camera here? This is the Protego system. This is a very easy to use, very nice device. It comes down from the ceiling. It completely cuts off radiation from the source, and the patient, not only does it cut it off from the source, but the patient is also draped with some lead-lined equipment. There's also lead down here, and my last 3 cases, Herms, have been zero radiation.
Wow. Yeah.
Zero radiation. I think we need to move in that direction. And this is not just for the doctors. This is for the technicians who, Herms and I may do 2 or 3 cases, but they do 10 or 12 cases a day. So it's for the nurses, the patient care technicians. This is the Protego system. And we and Beaumont Hospital are the only places in the country to have this. And we're working through trying to see where the heartburn or the pain points are with this system. But so far, I'm in love with this thing.
Yeah.
This is really spectacular. I'll talk more about that in a second.
David, are you wearing lead?
I am. We are wearing lead. We're mandated to wear lead until we have good studies done that prove the concept. This is early in the experience. Herms, pretty easy to get to.
Oh my gosh. I was really impressed with, we're able to get steep angles. It doesn't get in the way. Access is easy. This isn't something that's going to be cumbersome to implement.
And that's the point. It's not cumbersome. Okay.
You don't lose contact with your patient. You're still able to communicate.
I got radial access. I got femoral access on this side. If things were to go south, you'd probably move it out of the way. But it's just a little clip that comes up, and you move it out of the way, so we can get to the patient if we have to. But understand, we're trying right now with the early phase studies to determine how to integrate this into the everyday working schedule.
Yeah.
So, all right, let's go to the case. This is a 76-year-old male. Symptoms, risk factors for heart disease, previous stenting, obstructive sleep apnea. Had a nuclear stress test with LAD ischemia. So physiologically, Mort, this patient is very much justified to take to the cardiac catheterization laboratory based on symptoms, based on functional data. Next. So the interventional cardiologist who referred this case to us looked at both of these lesions and said, okay, I'm going to do multivessel intervention. He did the right first, okay? And then he went to do the LAD, and he could cross with the wire and a balloon. He crossed with the wire, but he couldn't get the balloon to inflate. He had it looked like an egg timer, yeah. And so he called, and I said, do nothing. I know exactly what we're going to do with this case. You can see that mid-LAD, and we'll show you some more pictures of this in a second, is high grade, and we'll show you just how calcified this is. Next picture. I think this is a beautiful case for the new C2 intravascular lithotripsy device. Herms, I think it's not rotoblator or lithotripsy. I think these are complementary technologies.
Mm-hmm. Yeah, I agree. I think we're going to need all the tools in the bag, but this is going to be a big tool.
So if you look at the new C2, you have an offset of the emitters. There's two emitters. One is 4 millimeters from the leading edge. The other is 2 millimeters from the trailing balloon markers. So you're going to have to probably move this on a lesion like this, do one part of this calcified lesion and then another part. Go next. Now, the way this works is the balloon is inflated to low pressure and a small spark emitters vaporize the saline contrast solution, creating a bubble, rapidly expanding and collapsing within the balloon, and you get these sonic pressure waves. The sonic pressure waves travel through the coronary tissue while reflecting off and cracking calcium, both superficial and deep. And you can actually see the balloon as you administer shocks, the balloon is going to inflate. Now, we're going to give about 10 shocks at a time, and we'll go over all that. I have Venkatesh Ramaya with us here.
Can I have the mic? Thanks.
So, Venkatesh, if those who remember the live case we did at Sky last year, or the year before in 2019, Venkatesh, interventional cardiology didn't come up with this. You guys have been using this in peripheral a lot, haven't you?
Yes, David. This is a remarkable example of how technology helps in treating calcium, because calcium is the bane of all interventions, especially in the periphery. So we started using shockwave for the SFA, and what it does is basically creates these emitters, create a channel and breaks the calcium in multiple places, as you'll see from BIML 2 on OCT. It allows the distensibility of the vessel with the balloon itself, and then allows for passage of large bore access vessels. We've used shockwave lithotripsy, especially for access for large bore instruments that we have right now. I started using it for AAA ELGs, and then of course for thoracic, and then TAVR started, and then Impella and other large bore devices came into the market. It's excellent technology. It causes no embolization. We have not had many dissections. And then it allows for better adaptation of stents to the arterial wall. So good technology to use in this case.
Great. So put the slides back up. Bimmel, I have found, put the slides up, please. OCT is a fantastic way to look at this, isn't it?
Yeah, I would say OCT is your test of choice to really look at calcium. So if you look at this vessel as it's going distal to proximal, what you'll find here coming in the next 10 millimeters is circumferential calcium. It's 360 degrees. Your former slide already looked at markers where you need to use atherectomy or some degree of calcium modification. So in this case, you could see 180 degrees. You see that calcium is not only superficial, but has depth to it that's more than 0.5 millimeters. And it actually has close to 15 to 20 millimeters in terms of length. So the calcium score of this is 4. OCT would be your test of choice to look at calcium score.
Beautiful.
And figure out what your strategy is going to be.
So go to the next slide, because I want to show a case that I just did a few days ago. This was a great case because we couldn't get anything past that proximal right coronary artery lesion. There were 2 lesions. So what we did was we shock waved the proximal lesion, and then I wanted to take the new Boston Scientific Megatron for a test drive. You know, every stent can suffer longitudinal foreshortening, but what we did was we put a 4-ohm Megatron, completed the proximal lesion first, because I really wanted to test this. We completed the proximal lesion first, and then we did multiple runs through the Megatron, and we placed a Xience stent. Xience stents are fantastic stents. It's often my stent of choice. And so this is the result we got. Go to the next slide. And Herms, this Megatron is an absolute beast. They have increased the proximal connectors, and it moves through the vessel very well, but there's very little longitudinal foreshortening, so there's axial strength and radial strength and longitudinal strength that the Megatron, I mean, they call it purpose-built. It's a beautiful stent, and it's a great stent for prox vessels that you're going to have to go through the stent with IVUS, OCT, et cetera. If you're an image guy, this is a great stent. And it adds to the armamentarium of Xience and other stents that we use that are really fantastic.
Yeah, and it's got a great name.
And it's got a great name. It's got a great name. Okay, so Why don't you show them, Herms, come live here.
Yeah.
Why don't you show them what the shockwave balloon looks like? We'll go to 4 atmospheres with
if you
this
can come
balloon.
down on my hand.
There you go. You can see the emitters. I think that's as close as they can get. You can see the emitters. We'll go to 4 atmospheres with this, and then we will OCT. So I think they're ready to go next door. What do you say we do a couple of shocks with this and then throw it next door? And then what we'll do is we'll OCT the result and consider Bimmel what size stents and Vinke what size stents we want to put in.
Dave, any concerns about crossing, looking at the old CT? Do you think this is going to cross easily, or we'll find out in a few seconds?
We're going to see in a few seconds. Got a lot of stuff on it.
It's sitting there.
No.
Yeah, hopefully we'll have
And
no
then
issues crossing.
I wasn't totally clear from the slide. Is the Megatron thicker than the regular Synergy?
No, it's just the connectors.
All right, so that's the only difference there.
Let me get one.
I don't think the struts are any thicker. You got the wire?
Got them.
All right, let's see. So here's the test. Now, is Dean up there? Because we're blessed to have Dean Kiriakis here, the PI for the pivotal. And if Dean can make some comments on this, that would be great.
I think Dean's swimming with his grandkids.
That's way more important. Okay, come move it with us. And look at that. Not a problem at all.
Very nice.
Not a
Very
problem
nice.
at all. Okay, so give me a little toot there, Herms. Let's see
Yeah.
where we're at. Okay, let me
You
get
got
a.
a little ways to go yet, huh?
Okay. Tell you what. I hear in my ear that they're ready to go. Okay, right
There
there.
you got it.
Okay, so go up to 4.
These voices in our head
I
can be
know.
dangerous sometimes.
4 atmospheres. Okay, now go. Now, is it armed? Okay, so we're going to give 10 shocks. We can give 10 at a time, and then we'll move. And we're seeing a little ischemia here. Okay, and down. And let's let him breathe. Let's let him breathe. I'm going to come back just a hint. Let's let him breathe. Okay, let's try it again. Are we armed? 4 atmospheres.
I think we may be a little distal, so we'll just see.
Really revolutionary technology for those operators, perhaps, that do a rotablator once every 3 or 4 months.
Down.
I think it's going to really be a game changer.
Great point, Dave. Herms and I chatted beforehand, and we think these are totally complementary.
Teeny scored here.
There we go. Oh, let me get that
Good try,
catheter
David.
out. There we go.
So,
me give you a
David,
little pop-up.
should this not replace the
There we go.
rotoblader?
So
No, I think they're complementary. I don't think anything should, I don't think it should be replaced. I think
now we're
they're-
really in it.
Now we're in it. Let's try it
You'll
again.
have to explain that to us.
Okay, give me
Yeah.
1 second.
I think what's fascinating, Mort, is that at least in our lab, there's only 2 or 3 guys that burr. And so not everyone does. I think what this will allow is every operator to approach calcified
Down.
lesions safer.
So if that's the
gonna come
case,
back.
we don't need a rotoblader, what you just said.
I'm curious to see what
There.
David
I like
says.
that.
Up.
Hey, Mort, this is Bimmel
There you
Pedalia.
go.
You know, I think this is where intracoronary imaging helps a lot. You know, it depends
You can
on
see
the
where it was.
distribution,
Yeah.
where the calcium is. You know, if you got nodular calcium protruding into the lumen, maybe you use
come back, okay?
both to, you know, get a larger lumen first, and then to hit and get the superficial calcium to crack with shockwave. What's the panel
Little
think of that?
test. Oh, look at that. That's gorgeous.
I think
Very
there's
nice.
probably still.
I don't know if they got your
proximal
point.
Still.
Looks like a good start.
Yeah.
Okay, so I wanted to give you an example. I think we're going to have to hit this again.
Yeah, I do too.
So we will, but I know they're eager to get going, and they got a really, really complicated case or complex case in the next room. We're going to hit this a couple more times with the device. Agree?
Yep.
And then we'll OCT it, and we'll come back, and we're just getting to know this device and learning more about it all the time. So I'll be curious to see what that OCT shows us, Bimmel. Why don't you go next door?
Thanks, guys.
So I want to show you the picture, the angiogram. We did a couple more shocks. Go ahead and show the last angiogram, the last cine angiogram. Now go back.
Dave Dean is on the panel
I
now,
heard.
so
We've
if
been
you have any
listening to him.
Specific
We heard
questions.
we heard a calm come over the panel because we figured Dean came out of the swimming pool with his grandkids and must have arrived. So this is the last cine, and looks great. Looks like we got
We had
great.
complete expansion of the balloon.
Right.
And,
And then, and sometimes, I'm told people will go to 6 atmospheres. Dean, you didn't see the original pictures, did you?
No.
Okay,
I
so
didn't.
go through the angiograms real quickly. Go back. Thank you. Keep going. So this is a case, Dean, where the patient has ischemia on a nuke test in the LAD territory. The original referring physician went down there, couldn't get the balloon to expand. When he called me, I said, stop. Dean Karyakis is coming to town. We'll do a shockwave and get Dean's commentary on it. And then if you go back one more picture, you can see just how much that's really a good look. It's a little obscured by the circ, but you can see just how much calcium is in that vessel and why it wouldn't dilate. So we did, how many shocks did we do total? 60. We did 60, and we could have done actually probably 20 more, and then go forward.
Did you OCT this
We're
to start
getting
with?
there.
You did, yeah.
We're getting there.
And what was your arc and thickness?
The arc was about 220 degrees originally. Go forward.
Yeah.
And go forward. And just go to the last angiograms. Yeah, there's our catheter. There's our balloon in there with the shocks. And this is what it looked like. Go next. Now, we did an OCT. Bimmel, that OCT catheter flew through there.
Yeah, I think the new version, the OpStar, has a lot, it's a little stiffer, it's a lot more deliverable as well, and it doesn't prolapse as much. So I think you found that even though this was significantly calcified, it delivered very well.
So probably the combination of a good lesion pretreatment strategy and this beautiful catheter. So wow us with some pictures now.
So this is a beautiful OCT run then, which will serve as your GPS on how to stent this lesion. So as we're going distal to proximal, the OCT run is overlaid with the angiogram here. And as we're going through the meat of the lesion here, you see, I'm going to stop it. There's a little bit of fibrotic lesion here, and you've got dissections into the media. And then as we go through the more fibrocalcific area, and you can see here, Dean mentioned, it's close to 360 degrees of calcium almost. And as you go through that lesion, post-shockwave now, you see these fissures, cracks into the calcium that you see. That's now going to allow our stent to expand. And I'll finish kind of playing this. We want to stent and use this lumen profile here in the middle to go close to normal. You go to the distal edge here where you see an EEL, and we've measured it just over 3, so we'll use a 3.0 stent. And then as we cover that entire diffusely diseased area, there's less of a normal segment in that proximal area. So what we did was we just went lumen to lumen and then upsize. So lumen to lumen, the mean diameter is 2.76. You could technically go up to 0.75 more. We'll go 0.5 more, and then we'll post-dilate this whole area with a 3.25. So the stent strategy here would be a 3.038 stent that will post-dilate 3.25, and then we can OCT at the end.
All right, that's perfect. Dean, observations?
Yeah, I'll tell you one thing you guys have already shown here is, and I think as people get using these devices, they're going to be surprised at the MLD they get with a 6-atmosphere inflation in heavily calcified arteries. And I think that's both because of the calcium fracture and the increased transmural compliance, but also it's the reduction in fibroelastic recoil. And if you look at the stepwise, what we put in the JACC paper for CAD3, just after a 6 atmosphere. That was the peak inflation pressure in that study, with an average arc of 293, an average thickness of 0.96 millimeters at the site of maximum calcium, 6 atmosphere inflation. You've got a highly significant increase in MLD, and sometimes you get stent-like looking results with a balloon. And that's because of the impact that this has on fibroelastic recoil and calcium fracture with increased transmural compliance. It also mitigates the need for high-pressure balloon inflation and barotrauma, which has been tearing up vessels for all of us for years. So this is tremendous.
Great points, and I want to draw a contrast and comparison. Look how beautiful, Herm's just remarked, look how beautiful that stent is. So this is a Xience stent. Really delivers the new Xience Sierra. It's been out a while, just delivers beautifully. And let's take a picture, Herms. Now, look what that lesion pretreatment strategy did. I might not have guessed, based on that they couldn't get a balloon to dilate there, that it would look that beautiful. But if you compare that to that right coronary, the contralateral vessel that was done several days ago, that stent had a lumpy, bumpy appearance to it. Look how beautiful and smooth that is. Bimmel, I saw you eyeing something over there. You didn't like the distal edge, or what were you looking at?
No, I think what you need to understand is this entire vessel, even if you go distally in the OCT, it has diffuse disease. It's fibrocalcific, lipocalcific. You're not going to find a normal segment. And so, we're not plastic surgeons. We like things to look perfect, but we're not going for perfect. Good is sometimes good enough, and we're able to check that with intracoronary imaging. And where you landed the stent, and we'll check on the post-OCT run, we wanted to make sure we weren't in a lipid area that can cause dissection. So I think we're going to look fine. There's just a nice little step down at the distal edge of the stent.
You were very, very precise. We call this OCT guided PCI, precision PCI. He was very precise with where he guided us to put this stent in based on a bunch of different parameters, but on OCT, but you were very, very precise.
Yeah, look, if we can just get a picture of the GPS there, and and that's just where we put it, right before that septal there, and so Bimmel said 38, and that was perfect.
Yeah, David, I think the key to making this work is to have the co-registered image on the angiogram. Otherwise, we still guess within plus or minus 5 or 10 millimeters where we put things.
Let me ask you a question, Mort. At these live case courses, there's always, Akiko is in the room or Bimmel is in the room, and we have somebody, doing the work, doing the hand stuff, and we have a second doctor really giving us precise information. And I know you can do both, but is that something we should be doing more often, especially maybe not here, but in the more complex cases where you have an expert at imaging giving real-time information? I just think a lot of people don't do precision PCI because they're not as good with the device, with the imaging. I don't know. What do you think?
Ideally that's the case, right? Somebody that is like Bimmel, hey, this is where you put the stent, this is what you got. It's just how do you make that happen, given everybody's busy schedule. It'd be great that you have somebody in your lab that is a technician and an expert at it.
So the reality, Dave, is that we don't have those extra bodies yet. We don't have the training path, and we don't have the expectations that somebody can routinely do this. For expert coursework, this is the way to go. But every day, I'd love to have somebody come in and do my imaging reading and say, hey, put it there, and I'll just go ahead and do it. But I have to be that same guy. And I think that's mostly what people are doing as opposed to having a Bimmel specialist hanging around.
It's like we don't have Akiko's like a ranger coming out of a helicopter. A rope comes down into the lab, and she comes down to save the day. And in the reality, it's hard to make that happen.
We just need a virtual Akiko coming out of the machine and just saying, put it there, right?
All I know is when it comes to what you have in the lab, Kenzie said, are you going to be able to do coronary intervention come Monday without a camera in the room? I said, to heck with the camera. I don't know what I'm going to do without Herms in the room.
Dave and Herms, I want to ask you guys and get Mort on this. You've got a great acute result, but, I think that this, quote, shockwave may be the gift that keeps giving. And Mort, I'd ask you, when you get MSA in our study of 6.5, you've got an average stent expansion of 102%, despite the ARCA 293 and a thickness of 0.96 millimeters. I mean, what would you predict from everything we've seen recently, including Ultimate, would be the long-term result in stents that are able to achieve that kind of MSA and percent expansion?
Your Honor, he's leading the witness. I think you're going to have a great result. But I just want to challenge you on this barotrauma. I think that shockwave balloon produces 50 atmospheres of trauma, which is 10 times whatever I've produced with a balloon. However, you cover it with a stent and everybody's happy. So I think your result will ultimately be very good.
In our practice,
complex dissection is 2.1%, and I've got the patient level pooled analysis with core lab adjudication, 628 cases. I don't know if Rob Riley's here yet, but he's going to present at ACC. The paper's in review right now in JACC CI. But I can tell you that the dissection rate, complex dissection, is under 3%. Perforation, abrupt closure, and no reflow in 628 patients with core lab adjudication, 0 after IVL. So
don't be so defensive.
got it. But and I have no stock ownership, no equity conflict here.
So, Dean, I want to be honest and challenge a little bit. We told Alok, go ahead and dilate before you do rotablator. Dave, I want to follow up on your comment, the idea that I think we've switched over. Have we?
No, we're here.
We're here? Okay, sorry, I don't see your dulcet voice, beautiful face. But I'm really confused by what you had said. Is the algorithm with this lesion shockwave first, or is it put a non-compliant balloon in, go to 1820, and if it looks like it fully expanded, then go ahead and stent? I'm just
It's an easy answer for me. I think this is yet to be determined. This thing just got FDA approved a couple of days ago, and we are still, I think the algorithm needs to be written. I think the algorithm, a lot of times the algorithm is, go up there, what does it look like to you? And that's how we make decisions on whether we're going to do roto. You can see that as an eccentric calcium based on the way the balloon looks. But I think that algorithm is yet to be written. And I think that is the great thing about being on the ground floor of this technology, is that those of us who are committed to this and to learning more about this are going to be able to contribute to that algorithm or write that algorithm under Dean's leadership and expertise. But I don't think we have the answer.
And I would say we don't always get perfect. This looks perfect.
Right. Right.
This is spectacular. We need to
Can I
image
just
this.
make one other point? Okay, what's my meter reading?
0.1.
Okay.
Everybody else has zeros.
Okay, so everyone in the room on their radiation badge has got a 0 radiation exposure. I've gotten 0.1 millirem. I've gotten 0.1, and I'm standing right on top of the patient. Sometimes, can you zoom in here on the wrist? Sometimes we believe there may be a little bit of radiation leakage here. As for the rest of the patient, he's covered. I've gotten 0.1. I could do 1,000 angioplasties this year at 0.1 and be in a completely safe radiation exposure threshold. I mean, how great is this?
Yeah, no, this is spectacular. And it doesn't get in the way.
And it's
Really,
not in the way at all.
We did this without any difficulty.
This system is called Protego, and I'm hoping that those busy interventionalists who are interested in radiation safety, which we all should be, will look at this so that we can generate a lot of really, really good science and get to the point that the lead is off our back. Herms, you made a comment about, my back hurts a lot of days, and I have no idea what my bone marrow looks like.
Yeah.
Probably too late for Herms because he's so old, but I think for everybody else that's younger, and I think this is really an important step forward.
Yeah.
David, as your patient, can you communicate with him at the head through that system?
Absolutely, absolutely. Our bartender gave him a bit of a heavy swig of something, so he's sleeping. But yeah, you can definitely communicate. I got windows here and whatnot, and it's easy to communicate. I'm getting the word in my earpiece that Sharma's ready to go. We'll do a final OCT, but let Sharma, let me just do a final wrap-up in our room, if you could. Show what we have. Show what we have, our last picture. So that's our last angiogram up on the screen. Are you guys seeing that? I think you're seeing the OCT. Give them the angio. Anyway, Bimmel, you want to talk about the OCT? And oh, there's our last angio, I see.
Yeah.
So the last angio, Herms, what do you think?
It's spectacular. I mean, that is just uniform, beautiful expansion angiographically.
Right. OCT, Bimmel?
So
in a word?
In the interest of time, just the proximal stent there looks well expanded. I've zoomed in here on where the microfissures and the cracks were in the calcium. Stent's beautifully expanded, and you can see OCT will give you a number in terms of what your expansion is. So over 90% expanded in that proximal segment with no evidence of edge dissections. Here's a proximal edge that you see. We landed it in plaque because that entire area is calcific, no dissection. So when you do precision PCI and you know exactly a GPS, you're going to have less indicators of MACE like dissections.
Venkatesh, broadly applicable.
Thanks, David. And this was an excellent case, highlighting, not only technology, but also the way to do an ideal case. I know we do this during conferences and all, but if we could put this into practice, every time you do a case like this, you will get ideal results and ideal technology for the ideal purpose. Two things have impressed me here. One, of course, is the shockwave technology that we extended to the coronaries. But more importantly, I think the Protego system is something that I'm really, really keen on. I do a lot of very complex fenestrated aortic cases, which take 6 to 8 hours. And there was a time when I was not allowed into the lab because my radiation levels were well above the limits of the state. And so I think David has brought in this technology, the Protego system, which I think should be looked into more in detail, especially from the vascular surgeon's point of view. And I think this is something that we all need to look into very closely.
Herms, by the time the average interventionalist has had 30 years in the lab, which you and I have and Venki has, the lead is not a pure cure. It's a barrier, but it's a disease process both in one. Back pain, et cetera, and it's not a pure cure. You're not getting protection on your face. By the time you've been in the lab 30 years, you've taken 50,000 chest x-rays in some cases to the face. Tell me about this case. When you're new technology, you don't take on the really complex lesions.
What I think about this case, it was a perfect demonstration case. This wasn't, hey, we're going to show you the outer borders of a technology. This is the kind of case where I think anybody can do this. And take a case that they wouldn't be able to do because they had an undilatable lesion, or even worse, put in a stent with stent regret, and do it like this in a very calm, easy fashion like we did today. So this was just a perfect demo.
All right, we're going to throw back to Alok. Thank you very much. I want to thank our friends from Shockwave. Steve Nelson gave us clinical support on this case. Friends from Abbott, Boston, and Protego. Great case. Thanks.